My name is Anita McLaughlin. I'm a health policy analyst for the American College of Radiology. I'd like to welcome you to the lung cancer screening webinar on coverage and payment, hosted by the ACR and supported by the Radiology Business Management Association and the Lung Cancer Alliance. This hour-long webinar will cover Medicare's national coverage decision on lung cancer screening and the latest updates on payment policy. Before I introduce you to our speakers, just a quick note about questions. Attendees can post questions to our presenters based on the time we have remaining following their presentations. Because of the number of attendees, we will accept questions posted online by using the webinar control panel. To submit a question for consideration, click on the small plus sign located next to the word questions on your webinar control panel located on the right-hand side of your screen. Our apologies if we do not have time to get to all of the questions. Any questions that we are unable to address online can be submitted to lcscoverage@acr.org. And with that, I'd like to introduce you to our two speakers, Drs. Ella Kazerouni and Geraldine McGinty. Dr. Kazerouni is a board-certified radiologist specializing in cardiothoracic imaging. She is currently Professor of Radiology, Director of the Division of Cardiothoracic Radiology, and Associate Chair for Clinical Affairs in the Department of Radiology at the University of Michigan Medical School Health System. She is an expert in cardiothoracic radiology with an emphasis on clinical and translational research. She is a past president of the American Rankin Ray Society, the Association of University Radiologists, the Society of Thoracic Radiology, and the Radiology Alliance for Health Services Research. She currently chairs the Committee on Lung Cancer Screening for the American College of Radiology. In addition, Dr. Kazerouni chairs the LungRAS Working Group and is the co-chair of the ACR Lung Cancer Screening Registry, and serves as a trustee of the American Board of Radiology. Her research interests include lung cancer screening as a site PI for the NLST and the implementation of lung cancer screening in practice with an attention to translating the efficacy seen in clinical trials into effectiveness in clinical practice. She has been a long-standing funded investigator in diffuse interstitial and obstructive lung disease, working to develop and validate advanced quantitative techniques to decipher imaging phenotypes of disease and deliver precision diagnostics. She received her medical training and completed her diagnostic radiology residency at the University of Michigan and performed her fellowship in thoracic imaging at the Massachusetts General Hospital. She also completed an MS in clinical research design and statistical analysis at the University of Michigan and is a graduate of the Hedwig van Emeringen Executive Leadership in Academic Medicine. Dr. McGinty is a board-certified radiologist specializing in women's imaging. She is currently Assistant Professor of Radiology at Weill Cornell Medical College and Assistant Attending Radiologist at the New York Presbyterian Hospital Weill Cornell campus. Dr. McGinty is an expert in healthcare payment policy and holds leadership positions in several important national organizations, including the American College of Radiology, where she is Chair of the Commission on Economics. Her research interests include healthcare payment policy and new payment models, as well as delivery of value-based imaging care. She received her medical training at the National University in Ireland, completed her residency at the University of Pittsburgh, and performed her fellowship in women's imaging at the Massachusetts General Hospital. She also completed her MBA at Columbia University. She recently joined the Board of Industrial Development Agency of Ireland. And with that, I will pass the control over to Dr. Kazerouni to begin her presentation.
Good morning, everybody, or I should say good afternoon, depending on which side of the coast you're on. Thank you very much for joining our lung cancer screening coverage and payment update today. I think this is historically probably the most subscribed, if not oversubscribed, webinar that has been put on by the American College of Radiology, and we're very grateful to you for tuning in today to learn more about this very timely and very important topic. It definitely shows the tremendous interest that is out there in learning more about this subject and in bringing lung cancer screening to your practices and the patients in the areas in which you serve. I'm going to talk a little bit about the background that's happened with lung cancer screening, particularly in the last 18 months, leading to a favorable CMS coverage decision for lung cancer screening with low-dose CT in February of this year. I'm going to touch on a couple of the important decision points in the CMS requirements for lung cancer screening, which include shared decision-making and a little bit about smoking cessation. A very important element of the CMS coverage decision is the requirement that sites participate in a quality and outcomes registry to look at benchmarks and monitor the evolution of lung cancer screening as it evolves from the research setting to daily practice amongst the large variety of practices that exist in the United States, both hospital and outpatient-based practices. Dr. McGinty is going to talk to us primarily about the coding and evaluation part of lung cancer screening CT, which is also an evolution, and these two components are very important for practitioners and administrators to understand moving forward. As we know, lung cancer is the leading cause of cancer death in men and women, and more people die from lung cancer annually than cancers of the breast, colon, and prostate gland combined. These are cancers for which we have had screening methodologies in place to reduce mortality. There's a large population at risk for lung cancer, predominantly due to cigarette smoking, with about 85% of all lung cancers attributed to smoking. The important science that's allowed us to come forward with a favorable coverage decision by CMS is that proven with the National Lung Screening Trial. The National Lung Screening Trial built on many earlier single-arm studies that showed you could find smaller lung cancers and improve survival, but because of their study design could not show a mortality benefit. That requires a randomized controlled trial. The NIH funded the National Lung Screening Trial, which was an 8-year study of over 53,000 subjects randomized to either annual low-dose CT for 3 years or an annual PA radiograph. The study was halted early because it met its primary endpoint of showing a 20% reduction in lung cancer mortality by annual low-dose CT. This study was published in the New England Journal of Medicine in August of 2011. The NLST also showed a 6.7% reduction in all-cause mortality. Another way to describe the outcome is that it takes screening approximately 320 individuals to save one from a lung cancer death, and that is only from screening with annual CT for 3 years, as in this trial. The other important data output from the National Lung Screening Trial is cost effectiveness. The National Lung Screening Trial's cost effectiveness analysis was published in the fall of 2014, also in the New England Journal of Medicine, and shows that lung cancer screening with CT is cost effective at approximately $81,000 per quality adjusted life year gained, well within the range of many other medical diagnostic and screening tests today. It is noted that the modest changes in the assumptions made could alter this finding, and we believe some of the things that are being put in place for lung cancer screening will make it even more cost effective. With these two data points, mortality reduction and cost effectiveness, the U.S. Preventive Services Task Force came forward with a Grade B favorable recommendation for lung cancer screening in December of 2013. This recommendation applies for annual low-dose CT screening for adults aged 55 to 80 years of age who have smoked at least 30 pack years. They must either be current smokers or smokers who have quit within the last 15 years. They also recommend that screening should be discontinued once a person has not smoked for 15 years or develops a health problem that substantially limits life expectancy or their ability or willingness to undergo curative therapy. What does a Grade B recommendation from the U.S. Preventive Services Task Force mean? A Grade B indicates either there is high certainty the net benefit is moderate, or moderate certainty the net benefit is moderate to substantial, that the particular service should be offered or provided. And this is the language of the U.S. Preventive Services Task Force itself. Importantly, under the terms of the Patient Protection and Affordable Care Act, it requires private insurers to cover, without a copay, all exams or procedures that receive a Grade B or higher recommendation. It does not, however, specify that Medicare provides full national coverage based on the U.S. Preventive Service Task Force deliberations. And that has been the source of continued activity over the last 18 months. In the fall of 2013, CMS also received 2 requests for a national coverage decision, which set in place certain activities to bring forward coverage today. Effective January 2015, because of the Affordable Care Act terms, with renewal dates of insurance policies by private payers, patients will be able to get lung cancer screening CT without a copay. Let's bear in mind that screening is a public health recommendation. Over the years, as data has been aggregating, many sites have developed lung cancer screening programs and are now considering developing screening programs if they don't already have one. As part of the National Coverage Decision thought process, CMS convened a MedCAC panel on April 30th of 2014 to engage in a dialogue and understand the evidence behind lung cancer screening with CT. At that panel, lung cancer screening CT did not receive a favorable recommendation. The reasons largely are concerns about whether the efficacy about what was done in clinical trials could it be translated into effectiveness in clinical practice. We know that the benefits of lung cancer screening CT are reduced lung cancer mortality. And secondarily, we may be able to detect other things, such as cardiovascular disease and coronary calcium, and emphysema and COPD that are smoking-related conditions and may contribute to morbidity and mortality. But concerns were raised regarding potential harms of lung cancer screening CT, specifically with regard to the detection of abnormalities and how they would be managed, and the treatments that are related to them. There were concerns raised about the ability to screen the appropriate population, which is largely determined by age and smoking history, because inappropriate screening of individuals who would not benefit or are at very low risk is not cost-effective and may cause more harm than good. There were questions raised about radiation exposure, and could low-dose screening CT truly be rolled out with attention to low dose? Concerns were raised around the management of positive screens and whether the subsequent diagnostic testing and procedures would be appropriate or overutilized. And concerns were raised regarding procedure-related complications. But we believe strongly that the evidence is there to overcome these potential harms if rolled out in practice appropriately. To this end, the American College of Radiology has worked hard to bring methodologies and programs to place to ensure the safe and effective rollout of lung cancer screening CT. The first of these was the ACR, Society of Thoracic Radiology, practice parameter for the performance and interpretation of CT for lung cancer screening. LungRads, a structured reporting and management tool, was also rolled out approximately a year ago. The ACR developed the designated lung cancer screening centers under the existing CT accreditation program, and most recently has released information on the ACR's lung cancer screening registry. And the 2 items that I will be talking about the most are LungRads and the ACR lung cancer screening registry. The ACR has put these resources and more on the ACR lung cancer screening resource webpage. Type into any search engine ACR lung cancer screening resources, and you will find a wealth of information related to the safe and effective practice of lung cancer screening and resources to help you in practice, including the fact that we're holding this webinar today. You'll see links to materials such as smoking cessation, to patient advocacy groups with information about lung cancer screening, and to screening decision aids. You'll also see important information on the AAPM protocols for lung cancer screening CT. The American Association of Physicists in Medicine has developed lung cancer screening protocols for 30 commonly used makes and models of CT scanners in place today to make it easy for practitioners to bring lung cancer low-dose screening protocols to their own practice. You'll also see a link here to the Lung Cancer Screening Practice Registry. In order to bring lung cancer screening CT through to coverage, which means reimbursement and being able to bring this to practice for our patients, it took a broad coalition of organizations across many disciplines. Well, at the heart of it were organizations like the Lung Cancer Alliance and the Society of Thoracic Surgeons working closely with the American College of Radiology, a multitude of organizations including the American Cancer Society, the American Thoracic Society and the American College of Chest Physicians, ASTRO, RSNA, the Society of Thoracic Radiology, and many other organizations, about 25% of which are represented by the logos on this slide. And together, by articulating that this could be done safely and effectively, and holding to the message that it's important to bring this screening benefit to those who need it, we have reached the point where we are today. On February 5th, CMS came forward with its national coverage decision for lung cancer screening. They approved screening coverage with annual low-dose CT for individuals aged 55 to 77. You'll notice this is different than the age 80 shown in the U.S. Preventive Services Task Force recommendation, and it's also different than the upper age that was used in the National Lung Screening Trial of 74. In fact, it's right in the middle. They recommend coverage for asymptomatic individual with no signs or symptoms of lung cancer who have smoked the same pack years and either current or former smokers as was used in the NLST and the USPSTF recommendations. Determination of beneficiary eligibility includes making sure we're looking at the appropriateness of age, the absence of signs or symptoms of lung cancer, and the number of pack years primarily. Shared decision-making, which may include the use of one or more decision aids that includes information about the benefits and harms of screening, follow-up testing, overdiagnosis, false positive rates, and radiation exposure is an important requirement of CMS coverage. And shared decision-making is required with the first annual screening CT examination that a patient begins their lung cancer screening program with. Patients should be counseled on the importance of adherence to an annual lung cancer low-dose screening protocol. This is not a one-time screening event. This is a series of continued annual screening CTs. Patients should be counseled on the importance of maintaining cigarette smoking abstinence if former smokers, and the importance of quitting smoking if they are current smokers. What is shared decision-making? I've included a definition here from the Informed Medical Decisions Foundation. Shared decision-making is essentially a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available as well as the patient's values and preferences. It takes into account the medical knowledge we have, the patient's individual circumstance to make sure that we're maximizing the benefits and minimizing the harms for the individual patient. For those of you interested in looking at a shared decision-making aid that's available on the web as a public access tool, I would refer you to Should I Screen, or www.shouldiScreen.com. A link to this is included on the ACR Lung Cancer Screening Resources webpage. This tool was developed using the well-known Tamamagi model for risk evaluation of patients and takes people through the pros and cons, the harms and benefits of lung cancer screening CT, as well as calculates their individual risk of developing lung cancer. This is a screenshot from the homepage of ShouldIScreen.com. Again, it will take individuals through the benefits and harms of screening and calculate their lung cancer risk. There are other patient education materials that are widely available, such as this electronic booklet that's used on the web, but may be printed as well, from the National Comprehensive Cancer Network. This is an online booklet that patients can page through and ask questions of their providers regarding whether lung cancer screening is right for them. You'll also find a link to this on the ACR Lung Cancer Screening Resource webpage. And this is simply what it looks like with navigational buttons to page forward and back to magnify the information and to fast forward ahead or print the materials. I mentioned earlier that smoking cessation is an important part of lung cancer screening. We know the best way to reduce lung cancer is to stop smoking or never smoke at all. And smoking cessation makes lung cancer screening more cost-effective. We've included smoking cessation in the ACR practice parameter for lung cancer screening CT, as well as in the ACR's lung cancer screening designated center program. Sites must have a mechanism in place to refer patients for smoking cessation counseling or to provide smoking cessation materials. You may have local, regional, or statewide lung cancer screening smoking cessation resources available to you. For example, in my state, we have a quit line with a 1-800 number that can not only provide referral to local resources, but provide some smoking cessation materials and patches to individuals who call. There are certainly national organizations like the American Cancer Society and the American Lung Association who also have available quit smoking resources. There is a large population at risk due to cigarette smoking for lung cancer and a much smaller population with secondhand smoke exposure. It's estimated there are approximately 60 million current smokers in the U.S. and about 30 million former smokers. With respect to lung cancer screening CT specifically, it's estimated that between 7 and 10 million individuals in the U.S. meet the age and smoking criteria laid out for lung cancer screening CT. Tobacco is the leading cause of preventable death and illness, responsible for approximately 1 in 5 deaths, including not only lung cancer, but COPD and cardiovascular disease. Many people are exposed to extensive secondhand smoke, and this may be the etiology or causative factor in a number of lung cancer deaths a year, but far many more heart disease deaths. Fortunately, secondhand smoke exposure is decreasing in the U.S., as much of the population is now covered by smoke-free policies in workplaces, restaurants, and bars. The American College of Radiology's Lung Cancer Screening Registry was approved by CMS as a qualified registry on March 5th of this year towards meeting the requirements for CMS coverage. We've leveraged the extensive ACR experience with the National Radiology Database Registries to bring the ACR Lung Cancer Screening Registry about quickly. Many of you may be familiar with existing near-dear registries such as the Dose Index Registry or the National Mammography Database, amongst others. For more information, please go to acr.org/NRDR or see the ACR's Lung Cancer Screening Resources webpage for a link. The major data categories in the ACR Lung Cancer Screening Registry include the appropriateness of screening, that is age and smoking history, as well as the absence of signs or symptoms of lung cancer, and not having any immediately life-limiting medical morbidities in the short term. The second major category has to do with the screening test itself, specifically metrics around CT radiation exposure, as well as the use of the LUNGRAD structured reporting categorization scheme. The third major data category is the outcomes for a patient within 12 months of a screening CT event. Did patients have subsequent downstream testing, additional diagnostic CTs or PET scans to follow up abnormal screening exams? Did they undergo tissue sampling, whether it's a percutaneous biopsy, bronchoscopy, or even surgery? And importantly, did they have a lung cancer diagnosed? We'll be monitoring all of these variables as part of the Lung Cancer Screening Registry tools that will be brought to bear to show practitioners how they perform, how their practice performs, and how they're performing with respect to normalized benchmarks across the U.S. We expect contracting to begin for this shortly after the AMCLC this year in May of 2015, with a target launch of June of this year. LungRads was released last year at the ACR's AMCLC meeting. Again, we leveraged the existing ACR experience with BI-RADS, now with 20 years experience and in its 5th edition, with several iterations as the available scientific evidence changed the recommendation or added to the requirements for structured reporting, management, and practice audit. By learning from the experience with BI-RADS, we were able to more quickly bring to bear LungRads, a structured reporting and management tool specifically for lung cancer screening, CT, and interpretation. The major question that LungRads was trying to address, in addition to providing structure, is how do we manage positive screens? In the NLST, over the 3 years of the trial, 40% of subjects had at least one positive screen within 3 years. In an earlier Mayo Clinic lung cancer screening trial over 5 years, 70% of people had at least one positive screen in the 5-year time period. Structured reporting will address the positive screen rate as well as the uncertainty about best management protocols for positive screens. While certainly there may be complications from invasive procedures that are necessary for tissue sampling and diagnosis, the complication rate from invasive procedures in lung cancer screening is quite low at approximately 1.4%. This is the typical, smoothly rounded, non-calcified, indeterminate pulmonary nodule for which we need to have clear, consistent management strategies. Similar to BI-RADS, LungRads has categories with increasing number representing increased risks of lung cancer. The categories are 0 through 4. There are also 2 modifiers, S for clinically significant or potentially clinically significant other findings not representing lung cancer. While mammograms are primarily designed to evaluate the breast tissue for the presence of lung cancer, chest CTs have been in practice for over 30 years. And with that, we know we can find many abnormalities on CT scans, ranging from other tumors that may sit within the thorax, to aortic aneurysms, severe coronary arterial calcification, and upper abdominal masses, such as incidentally detected renal cell carcinomas and other masses. When we identify clinically significant or potentially significant findings other than lung cancer, we need to make sure these are clearly and effectively communicated. The C modifier is for a prior diagnosis of lung cancer for patients who return to annual screening after a significant disease-free survival. With the data elements in LungRads, it facilitates the type of practice audit that we'll be using in the lung cancer screening registry. This is what LungRads looks like. Incomplete is category 0 all the way up through suspicious, the highest risk category, level 4. Incomplete LungRads would be an incomplete chest CT exam, perhaps because of a patient breathing, or an unexpected acute abnormality that is masking part of the lung, which cannot be well evaluated. These would be patients who would come back to complete their screening exam before an official code of 1 through 4 could be assigned. Category 1 is an outright negative exam with no nodules or definitely benign nodules, such as calcified granulomas or fat-containing hamartomas. Category 2 is benign in appearance or benign in behavior. These are nodules with a very low likelihood of becoming a clinically active cancer due to either small size or lack of growth. Together, categories 1 and 2 are used to define the total number of negative screens. Categories 3 and 4 are positive screens. Category 3 is probably benign, but we recommend a short-term follow-up because while the likelihood is low, when we're seeing nodules for the first time, we need to ascertain their lack of change and therefore slow biologic behavior. Category 4 are the most suspicious lesions for which shorter-term testing or all the way up to tissue sampling should be considered based on the abnormalities. This is the distribution in which you can expect CTs done for lung cancer screening to fall. It's expected that about 90% of all exams will be Category 1 or 2. That's 9 in 10 of the patients screened using lung-rads. And approximately 4% will be Category 3 and 2% each in Category 4A and 4B. You'll notice this does not add up to immediately 100% because there's probably a slight variance around those small numbers. If you look at the probability of malignancy associated with each of these categories, you'll notice that it also gradually increases, with Categories 4 being the highest risk lesions. Now, there are many details as to what type of nodules fall into which categories, and it's not the intention of this webinar today to go into the details of each nodule type and nodule size. I'll show you some brief definitions of which nodules fall in which categories, mostly as an introduction. For negative overall screens 1 and 2, we recommend continued annual screening with low-dose CT in 12 months. For lesions that fall into Category 3, we recommend a 6-month low-dose CT. And if the abnormality is unchanged or resolved, to return to the annual screening calendar. People tend to remember their annual health behaviors and health maintenance as an annual term. Similar to mammography or bone densitometry for osteoporosis, people often remember the month of the year in which they should be screened. Category 4A lesions should undergo a 3-month low-dose CT, and PET might be considered if there's a large solid component. If negative, unchanged, or smaller, they would return to their annual screening calendar. Category 4B are the most suspicious lesions where the decision as to what a patient should undergo should be determined by the probability of malignancy and comorbidities in the individual patient. This is the type of multidisciplinary program that a patient might be sent to that includes pulmonary medicine physicians, perhaps radiation oncologists and thoracic surgeons, as well as radiologists. The range of tests that might be used here include chest CT with or without contrast, PET CT, or tissue sampling. A fundamental question that we had to address with lung rads is, what's a positive screen? The NLST used 4 millimeters to define a positive screen. And when 4 millimeters or bigger is used, 27% of people had a positive screen at their baseline or next year's annual screen. This only fell to 17% at the 3rd year or T2 screen because nodules that were considered stable over 2 years could be considered benign, but were not required to be considered benign in that trial. So using a 4 millimeter size threshold means over 1 in 4 people in the first couple of years of screening would have a positive screen. And that results in the cost effectiveness that was seen in NLST. There's been additional work published since NLST began in 2002. This is some work from the LCAP group in the Annals of Internal Medicine that looked at alternate size thresholds for defining a positive screen and the impact of different sizes on cancer diagnosis. In over 21,000 individuals screened between 2006 and 2010, when a size threshold of 5 millimeters and larger was used in LCAP, 16% of people had a positive screen. If you increase that by 1 millimeter, from 5 to 6 millimeters, the positive screen rate falls to 10.2%, and 36% downstream diagnostic tests would be performed. You go up yet another millimeter to 7 millimeters, and now the positive screen rate is 7.1%, with a 56% reduction in downstream diagnostics. We chose 6 millimeters as the point for solid nodules to define lung rads positive and negative. Importantly, the 9-month delay in cancer diagnosis between going from 5 to 6 millimeters was 0%. And it started to gradually creep up with each incremental threshold change. This has since been applied to the NLST. The notion of alternate size thresholds was addressed in the very same NLST population. And going from 5 millimeters up to 8 millimeters, NLST investigators also showed you could reduce your positive screen rate and your false positives. Raising the nodule size substantially reduces false positives and medical resource utilization. And it's important to make sure we track outcomes. In NLST, almost 2/3 of positive screens had the largest nodule, being 7 millimeters or smaller. The second important concept we used in LungRADS was the revised adenocarcinoma classification that was published in 2011. It takes the smallest ground glass nodules, which are AAH, or atypical adenomatous hyperplasia, all the way up the spectrum to bigger ground glass nodules that are adenocarcinoma in situ, ground glass nodules that develop a solid component known as minimally invasive adenocarcinomas, all the way up right to the invasive adenocarcinomas. The AAHs, or hyperplastic lesions, are thought to be pre-invasive. And adenocarcinomas in situ can be ground glass nodules up to 3 centimeters in size that have a complete resection survival of 100%. Many people believe this contributes to the overdiagnosis in lung cancer screening, that is, cancers that people would die with but not die of or from. It's when we get to minimally invasive adenocarcinomas where we have predominantly ground glass nodules up to 3 centimeters that have developed an invasive component. That small invasive component appears on CT as a solid component, and minimally invasive adenocarcinomas therefore appear as part solid nodules. Invasive adenocarcinomas we're much more familiar with are the solid lesions and solid lesions that develop spiculation. So importantly in LungRADS, we use baseline nodule size and growth versus stability, as well as nodule consistency in deciding what nodules go into which category. Using LungRADS reduces the positive screen rate from over 1 in 4 to approximately 1 in 10. Here's the 3 major classifications: the solid nodule, the part solid nodule, and the non-solid nodule, which you may be more familiar with as a ground glass opacity or ground glass nodule. Each category is divided up into solid, part solid, and non-solid nodules and size criteria. And the important one to know is that solid nodules under 6 millimeters are considered negative screens at the baseline screen. And if a new solid nodule develops in the future, anything under 4 is considered negative. The same size threshold of 6 is used for part solid nodules. And for ground glass nodules, because of the adenocarcinoma in situ and atypical adenomatous hyperplasias, we use 2 centimeters as the size threshold. In category 3, the lesions are simply a little bit bigger. And in category 4A and 4B, they are again bigger with each category, increasing the probability of invasive adenocarcinoma or minimally invasive adenocarcinoma. 4X is where we allow radiologists to upcode category 3 and 4A lesions to the same management protocol as 4B if there are other suspicious findings, such as lymph nodes, pleural effusions, or other features like spiculation. It has been shown that the radiologist's prediction of malignancy is an important component in identifying lung cancer. LungRADS has been applied in the Leahy Clinic population, where Dr. McKee and colleagues applied it to over 2,000 high-risk individuals undergoing CT screening in their practice. They showed that LungRADS reduces the positive screen rate down to near 10%, with no false negatives in the patients they followed for more than 12 months, and an increasing positive predictive value for malignancy. The NLST has also applied LungRADS retrospectively to the NLST population. And whether it was the baseline CT or the subsequent annual screens, LungRADS reduces the false positive rate, reduces the sensitivity, which we'll talk a little bit more about, and increases the positive predictive value for lung cancer screening. What is it we're missing with the lower sensitivity? Well, the nodules that lung-rads reclassified as negative, that NLST had originally called positive, were either nodules with no growth or were pure ground glass non-solid nodules. We believe this may be some of the overdiagnosis in lung cancer screening related to adenocarcinomas in situ, or adenocarcinomas with a very slow biologic behavior. Now, since we've reviewed the important coverage elements in the decision by Medicare, the requirements of participating in a lung cancer screening clinical quality registry, shared decision-making, smoking cessation, as well as the age and smoking criteria, I'm going to turn this over to Dr. McGinty to talk to us more about the specific coding and evaluation of lung cancer screening CT.
Thanks so much, Ella. A couple of things. First of all, I just really like to thank Ella for her leadership through this process. It was a pretty intense year for everyone involved last year, and she certainly guided us along very expertly. But also a huge thanks to our ACR staff, many of whom are on the call with us today, who really were very critical and instrumental, not only to getting the coverage decision, but also to developing the registry, which I think was such a critical part of it. Unfortunately, I'm probably not going to be as specific as many of you would like when talking about the coding, because even though Medicare has issued its final coverage decision, some of the coding and billing specifics are really still up in the air, and that's entirely within CMS's normal process. This is nothing out of the ordinary. I just wanted to give you a sense of what we at the ACR have done since the final coverage decision came out in February. And pretty much immediately after that, we met with the coverage and payment groups at CMS, the Centers for Medicare and Medicaid Services, just after that coverage decision in February. And that's two separate groups within the agency. And the coverage group were the ones with whom we had worked throughout 2014 to determine whether Medicare felt that a decision to cover lung cancer screening was something that they should do. The payment group is the group that will essentially decide how the service should be coded, billed, and paid for at what rate. So the process is that the coverage group, and this is somewhat simplified if we have any experts in the process on the call, but the coverage group will issue what's called a change request to the payment group, and then the payment group will develop the payment policy. And this process can take several months. So as I say, we're still very much within Medicare's normal process. So what are some of the things that we discussed with the folks at Medicare about this new service of lung cancer screening? Well, anyone who's familiar with the whole CPT RUC process will know that it can take up to almost 2 years between developing a new code and then sending it through for valuation and having Medicare decide whether it accepts that valuation and then finally getting it into the fee schedule. So with the goal of having lung cancer screening paid for in 2015, we recommended to Medicare that they not go through that whole process, but that they consider using what's called a G-code. And anyone who performs or bills for mammography services is familiar with the G-code concept. G-codes can be created by Medicare at any time, and Medicare can set the pricing for them. So it definitely can bring a service into general usage more quickly. So that was the coding constructs that we suggested. Typically, when you look at services across the Medicare fee schedule, you'll see that screening services tend to be paid at a lower rate and have a lower RVU value than their diagnostic counterpart. So obviously, the first thing that we really looked at when thinking about what would be an appropriate reimbursement to make sure that this life-saving service is available to Medicare beneficiaries, we started off by looking at the non-contrast chest CT. And, one could ask oneself, perhaps this is the same? Well, we feel for a number of reasons that it's not the same, and this was the heart of our discussion with Medicare. The fact that we're really doing the lowest dose possible, it's a lower resolution set of images, actually, for those who read them, makes it more challenging. You've heard from Dr. Kazerouni the robust quality program that we recommended to Medicare and that they adopted in their coverage decision. Those robust quality activities take time and resources. Anyone, again, who offers mammography services knows how challenging it can be to make sure that you have the appropriate resources to meet all those quality activity requirements. Structured reporting is really a new paradigm and involves the radiologist in outcomes and management recommendations, again, that take more time and intensity, that responsibility for following up. So we had a robust discussion with the agency about how we believe that this service, this lung cancer screening service, is not a, shall we say, routine non-contrast chest CT, and as such should not be coded and billed for in that way. And those of us who, and I work extensively within the CPT RUC payment policy process, so we have a lot of templates that we use and processes that we go through to think about the work that's associated with the service and the resources needed. So what we did for Medicare was we modeled out, based on the clinical expertise from Dr. Kazerouni and her group and other practicing physicians, what we thought would be the time, intensity, and resources needed for centers to perform this service. We had some other concerns with the agency, possibly a little bit tangential to us as interpreting radiologists, but there's definitely been some concern and some questions out there in the referring physician community about the shared decision-making visit that is required as part of coverage for lung cancer screening. Our question to the agency was, when does this happen? Because we have a concern that if it has to happen separately to a regular visit, that may be something that will dissuade beneficiaries from accessing this life-saving benefit. We are not sure how the agency is going to rule on that, but we certainly feel as if it should be something that a practicing physician or provider can add into their existing encounter with the patient. And on the longer term, with this and many other screening services, we do have concerns about cost sharing for follow-up care. Although the initial screening CT is, under the terms of the Affordable Care Act, paid for without cost sharing, any follow-up care, things like biopsies, do have cost sharing, which could be substantial for beneficiaries. And again, we would not want to dissuade a beneficiary from pursuing this life-saving care because of cost sharing. So that's Medicare. So in essence, Medicare is on hold right now as the agency goes through its processes. But in the commercial payer world, there's already a code out there. In the fall of last year, an S code, code F8032, was created that private payers can use for lung and must use for lung cancer screening. If indeed Medicare goes on to create a G code, as we've suggested, the private payers can choose to use that G code, but they can also stick with the S code that they've been given already. Initial intelligence from around the country, and I don't know if we have any payers on the line, are that we're seeing variable payment rates. Certainly have seen some concerns about rates that are significantly lower than the chest CT, and again, our goal is to make sure that this service is reimbursed at a rate which will allow it to be accessible to beneficiaries, so that the benefits that we know can accrue will actually happen. We have not heard a lot of feedback. In fact, really haven't heard any feedback from private payers about requiring registry participation and or requiring the types of robust quality activities. And again, it's early days. But I think our sense is that if you're going to track the outcomes of your Medicare patients, it's obviously going to be most useful for us as a profession, as a healthcare delivery system, if you do that for all of your patients. We've heard some rumors that some private payers are telling providers to use 71250, the non-contrast chest CT code, and we don't believe that that's an appropriate way to go. Not only do we feel it's a fundamentally different service, but we feel that the ability to track that service, track how it's performed and how the beneficiaries do with it, is absolutely essential for a good program. So what do I do today? Well, for Medicare, hold your claims. You heard our registry is going to be up and running, we hope, in June, so hold your registry data. Medicare will pay for this. It is a covered service. So they will pay for it. We don't know yet at what rate, but you cannot bill Medicare beneficiaries out of pocket. You cannot get them to sign a waiver and bill for it. It is a coverage service. And then at the local level with your private carriers, make sure to advocate for fair reimbursement with them. Make it clear to them that, you know, we've established a very robust quality program. This is a life-saving service, and that we need to make sure that it's available to beneficiaries, and that, you know, we would also encourage you to adopt the same standards for all of your patients as Medicare is requiring for Medicare beneficiaries. So I will stop there. I imagine we probably have lots of questions, and thank you all.
At this time, we'll take questions that have been submitted online. So again, just a reminder about questions. They'll have to be posted online for us to review. So several of you asked whether the slides will be available. Yes, they will be posted online, and the link will be sent to all registrants. A quick question at the end, and then I'll go through the questions in order. This is for Dr. McGinty. Could you please repeat the S code that you mentioned for commercial payers for lung cancer screening?
Sure. S as in Sam, 8032.
Okay, so taking the questions again from the top. For consistency, should we start using the Lung-RADS criteria versus the Fleischner Society that we do now, whether the test is a routine CT or a lung screen? And this is from Diane Case.
Thank you very much for that question. This is a very commonly asked question. Lung-RADS is applied for screening CT, and I would recommend that you begin to use Lung-RADS in practice for screening CT. The Fleischner nodule management criteria have been well used for quite some time, and they were intended to be used for incidentally detected nodules. Suppose you have a 45-year-old who has an incidental nodule detected, smoker or non-smoker. There are clear criteria in there for following nodules, and when they become stable over time, nodule management stops, and that there's no continued follow-up. A screening program allows annual checks on nodules through many years of screening, whereas incidental nodules are essentially managed and done, or managed and out, so to speak. We've been having some discussions with the folks who wrote the Fleischner criteria, Heber McMahon specifically, and they will be revising the Fleischner criteria, we expect later this year. And we're also putting together a manual of operations for Lung-RADS, which will make it clear what Fleischner is to be used for and what Lung-RADS is to be used for. There will be some overlap in the middle, as there are going to be some people with incidentally detected nodules who meet age and smoking criteria for screening. And in that population, I'd recommend using Lung-RADS and recommending patients become enrolled in an annual lung cancer screening program. Thank you for that great question.
There were a number of questions about the logistics of the registry, and I answered them online. All of you should be able to see those answers. So moving on to the next question for Drs. Casaroni and McGinty. Do screenings need to be billed using the S code? If the ordering provider has obtained authorization using the CPT code, can we bill it under 71250?
So I presume we're talking about a commercially insured patient. We're not talking about a Medicare patient, obviously, if we're talking about authorization. And it is our position that the S code is what should be used for a screening CT. We do know that we've heard anecdotally that at least one of the radiology benefit managers is using the 71250, but we believe that the S code should be used for commercially insured patients who are getting a screening low-dose CT.
And I believe you just answered the next question that I was going to read out to you. What CPT code does Medicare want billed?
So that's a great question, and we're anxiously anticipating the answer. And again, if they decide not to use the 71250, the chest CT code, which would be our recommendation, if they decide not to do that, they have a choice. They can either create a new CPT code, which will take some time, or if, as we advise, they want to get this billable in 2015, they would almost certainly have to use what's called a G code, which is not a CPT code. And if you do mammography, it starts with a G and it's got 4 digits.
Are you aware of recommendations on how referring physicians should document, from a billing point of view, the fact that counseling has taken place prior to the order being entered?
Ella, do you want to take that one? Or?
Sure. What we've advised people to do is to make sure that in the records that the radiology practice maintains, that the order for lung cancer screening include an attestation that shared decision-making has taken place. There are going to be a variety and a diversity of lung cancer screening programs and practices, from wholly integrated health systems where everybody has access to people's medical records and they're within its system, and you might have that there as a very easy check in a closed health system. But in many practices who work with referrals from other practices or health systems, physicians' offices, you may need to have that on your screening order form as an attestation from the ordering provider. And we've actually chosen to take both models in our practice, which is largely a closed health system in terms of where most of our patients will come for screening, but we also see many patients who come from outside physician practices. So we have developed a blended approach that both includes the attestation in the order for the inside and the outside referring providers.
Next question. Even though CMS officially approved coverage February 2nd, did you say private carriers that have self-funded contracts that are not up for renewal do not have to cover until the next contract is executed?
In general, their requirement for coverage in 2015 starts with their plan year. If there's a specific question, I'm going to suggest we take that offline.
Next question. What are some of the ICD-10 codes that are payable for this scan?
It's a screening study, so I'm not sure I'm understanding the question.
And maybe this is another that we can answer offline. And I think if you have specific questions, please send them to lcscoverage@acr.org, and we'll get back to you. Next question. If a person smokes 2 packs per day for 15+ years, would that meet the pack year average requirement, since it is double the amount but for half the time?
Yes, the calculation of pack years is taking the average number of pack years a patient has smoked and the total duration which they have smoked. So 2 times 15 would make the 30 or more criterion. We do recognize that some people may have variable smoking patterns over time, and in general you should take the preponderance of what they've smoked and for how long in calculating the pack years. So if somebody smoked 1 pack a year for 10 years and then 3 pack a year for the next 10 years, you could average those time periods together. But simply, the most simplest is the total number of years smoked and the average pack years during that smoking period.
I know we're a little bit over time, but we're going to just keep taking a few more questions, I think, for about 5 more minutes or so. At some point during the presentation, I would like more information about who is supposed to do the shared decision-making with the patient, the primary care provider, and or the lung cancer screening program provider. If shared decision-making happens at both points, will both be reimbursed?
CMS has not really finalized their thinking on how that shared decision-making process should be coded, billed, and reimbursed. The language, and Ella can please feel free to jump in, but the language does not preclude the imaging facility from doing the shared decision-making, but I believe it's our thought that this will much more likely be happening with the patient and their primary care physician.
And that's my understanding as well.
There are 2 questions, one on smoking cessation and one on shared decision-making, and I think I can ask them together. Who is responsible for supplying the cessation material to the patient, the referring physician, or the radiologist's office? And are we going to be able to do phone-based shared decision-making with patients?
I think those are both some very interesting questions. I would encourage radiology practices to get in the habit of offering smoking cessation materials when patients come for lung cancer screening CT. Patients can't hear the message often enough about the importance of lung cancer screening, and it's not that difficult to have smoking cessation materials available for patients. I think the people they tend to have the relationship with is their primary care providers or physicians that they see on a regular basis. And the discussion about how smoking cessation plays into their overall health maintenance is probably best managed with their referring physician.
Will outcomes at 12 months from screening CT event requirement be only for the facility's records?
That's an excellent question, as we do recognize there is effort and resource necessary to be able to get outcomes information for patients and to be able to make sure that the information being obtained is medically reasonable, therefore the involvement of physicians and radiologists in making sure the information collected is sound. It is the expectation that it will not just be within the practice or the hospital or the multi-specialty clinic where a patient's getting screened, but that we're trying to collect outcomes on how lung cancer screening is working in practice to make sure the benefits are brought to the population the way they've been done in clinical trials. And that will require sites to try and get that information outside of their own local facility.
We are considering an imaging center that will be doing the CT scan. Do we need to provide information to the patient about smoking cessation interventions, or does the doctor's office do this? I guess that has just been answered, so I'm just going to move on to the next question. Is this a voluntary reporting option at this time? Is it expected to be mandatory in the future?
Paolo, do you want to? Well, the registry participation is part of the Medicare coverage decision. Is that the question, or?
Yes, I think that is what it sounds like. Is
okay.
it a voluntary reporting option at this time? Yes.
If a site wants to screen CMS-covered individuals, then it would not be optional. If a site were not to screen Medicare individuals, then the requirement would not exist. So to the extent that practices are seeing Medicare beneficiaries, a registry requirement is necessary. Right now, the American College of Radiology has a CMS-approved registry. I'm not aware of others that have been approved or are considering applying to be approved, but that could happen. There might be another registry. Right now, we believe we have the first registry and the most thorough registry and the one that radiologists may be used to interacting with based on the other registries that ACR has.
I think maybe two more last questions. Will there be a dedicated CME activity for radiologists around these guidelines and disease entities?
The ACR is developing a hands-on educational tool about lung cancer screening, interpretation, and nodule management. It includes the recommendations for who should get screened, as well as many case examples and education around lung rads, and this will be a web-based tool. I think you should look forward for future educational activities that are brought to bear. The ACR co-sponsored the STR, Society of Thoracic Radiology's Lung Cancer Screening Symposium this year, which was a full-day symposium that will have topics available on the STR website. Certainly we'll post links to those on the ACR website too, about educational content with respect to lung cancer screening, and we're working on several educational activities to bring forward as well. At the annual meeting, the ACR's annual meeting this year, there will be a lung cancer screening session on Sunday, as well as a Q&A session over the noon hour to answer people's questions about lung cancer screening.
I'm going to ask one last question, and I think we'll respond to the rest by email. What if the patient coming in does not meet lung screening criteria? Is it correct to perform a CT chest in the screening place with an updated script from the referring doctor?
Geraldine, you want to handle that one?
Sure. I mean, obviously, CMS has been fairly clear on the criteria. So if the patient meets those criteria, then they get a screening CT. If they do not meet those criteria, they're not a screening CT. So if there's a reason for them to have a CT, yes, that would require an updated order, depending on the site of service. And again, probably out of the scope of this conversation, but would require an updated order from the physician.
Okay, with that, we're going to close. Thank you, everyone, for attending today's webinar on lung cancer screening. For questions about coverage, please note the contact information on the slide, in addition to the email addresses for the registry and screening designation. Also, as included is the link to the ACR's lung cancer screening